Hey guys, can you see me? Can you hear me? I'm back to torture you guys. Am I audible, visible, guys? If so, say me a hi and a hello. I'm supposed to see you guys on Sunday, but I'm back to torture you guys today and tomorrow because the Racha will be taking it on Sunday. Fine. Uh, Good evening, Ipshita. So we'll look at WBC and we'll look at neoplasia tomorrow, so that we'll at least complete a few things which are important for exam point of view, and then whatever is left behind, we'll look at them after some time, right? Okay. Hello. Thank you. Thank you. Hello, Srimati. Good evening. Hi, Singh. Good evening. Hello, Safar. Good evening. Fine. So let's start. WBC is something which is important for you guys. There is very likely chance that might be a one long answer coming in either an RBC or WBC with respect to hematology, because both of them, RBC as well as WBC might have been a bit difficult when you read, but it's very easy when you recap and when you revise, right? So this entire module is on how to revise WBC, how to write in an exam. First and foremost thing, I want you to give some keywords so that you can make the right diagnosis in a long answer question, because that's the first trouble. WBC with respect to leukemia or lymphoma, leukemia does not have a very straightforward pathogenesis, just a few mutations. Lymphoma, again, it's a very classical and a very easy template for you to remember, right? But diagnosing it is something which is very important, right? So there are a few keywords which I want you to remember to diagnose in LAQ. The first and the foremost thing, never miss on the age. Age is a very important clue for two diseases, right? Like or not for AML, you're absolutely right, Srimati. I wish your examiners gave such an easy clue so that no one will have a problem at all, right? Most of the lymphomas, leukemias, elderly person or middle-aged adult. But like I said, there are two important things which can be even diagnosed with age. If it's a WBC long answer question, leukemia or a lymphoma, and if the history is in a child, it's a very important clue. Child, I have only two possibilities: acute lymphoid leukemia, Burkitt's lymphoma. With respect to an undergraduate, yes, when you go to an internship, you might have a little bit of more things coming into play as well, right? For an undergraduate, for a second year, if there's a child in a WBC question, think of an ALL or a Burkitt's lymphoma. How to differentiate them? Very simple. Burkitt's is lymphoma, solid organ, lymphadenopathy, or a hepatosplenomegaly, right? ALL will have just a classical lymphadenopathy with blast in the microscopy. Burkitt's will not have blast in the microscopy often, right? So this is something which I want you to remember first. Second, hydrogen. Second, when you have, there are few features very common. This will not decide the diagnosis. Just because there is this feature, don't think it's AML or ALL. This can be uniform across every lymphoma, every leukemia, right? One, you have features of anemia, that's fatigue. You have features of thrombocytopenia, like a bleeding gums. Okay, these are very non-specific. It doesn't say it's a lymphoma, it's a leukemia, it's an AML, ALL, right? It's just non-specific, right? Bleeding gums, you have anemia, you have, or just a fever, which is due to reduced WBC count. So all these are features of bone marrow being involved by leukemic cells or lymphoma cells, right? Hi, doctor. So these are very non-specific. Don't say that, okay, I have a bleeding gum, so it's an AML. Not at all. Okay, that's amazing, Nagor. Keep doing well. Yeah. Yes, Rishank. Okay. Second, when you have a question saying there is a generalized lymphadenopathy, this again is very non-specific. It doesn't mean any of the specific diagnosis, right? Okay. Great, Hariom Nagor. Very happy for you. Keep reading. Fine. So these are two very general symptoms. This does not mean any diagnosis. Do remember that as well. Fine. Okay. So we know few clues for us to remember, and we know few common distractors for you to ignore, right? Then there are few more classical important clues here, right? When you have a question with respect to an undergraduate with massive splenomegaly, come on guys, tell me the answer. This I'm sure you will know it. What's the answer? I'm going to think of by default CML, right? This is not difficult. Massive splenomegaly, elderly person, leukocytosis, you will think of CML. These are very important clues you should never miss. Missing this is criminal, right? At the end of second year, if you miss massive splenomegaly when CML, it is going to be difficult, right? Okay. Next, let's say I have gum hypertrophy. Say I'm not saying gum bleeding. Please do remember gum bleeding and gum hypertrophy are two different findings. Don't equate it. Fine? Never equate it. Okay? Fine. So gum hypertrophy, I'm an MD pathologist, Zafar. So gum hypertrophy, think of an AML M4 or an AML M5, right? So that is very important for you to remember. Most likely AML M4 M5, but yes, M2 also I will be able to see gum hypertrophy. Doesn't matter, but always AML M4 and M5. Never ever forget it, right? When you have in a microscopic finding, when you have smut cells, what's the diagnosis? These are spotters, right? Right? This is spotters, smut cells. Perfect. It is CLL, right? It's a classical CLL. You have to think of a CLL. Okay, fine. Next, when you have in the question, like in the start itself, Srimati asked and said, when you see or rods in the question, I'm going to think of acute myeloid leukemia. There is a patient with DIC as the clinical feature. Fine. Yes, Rishang, because of the macrophage involvement, it goes to the soft tissue. That's what it is, right? Whenever you have a patient with some random leukemia findings like or anemia or bleeding gums, plus there's DIC. DIC as a presenting feature, what is your diagnosis? DIC can be a presenting feature only in one type of an AML, which is AML, M3 or an APML. Okay? Acute promyelocytic leukemia will have DIC as a presenting feature. None of the other leukemia will have DIC as a presenting feature. Remember, only APML can have the DIC as a presenting feature. Raj Purohit, yes, sepsis definitely true. Fine. No, Rishang, very, very unlikely because the blast percentage in case of an CML is less. So OR rod might not be a finding, but yes, for a theoretical purpose, I can see OR rod in a CML as well. Fine. Okay. So these are clues I don't want you to miss. Burkitt's, obviously, you know, the jaw swelling. A child with a jaw swelling, again, making it a wrong is criminal offense. I don't make blunders because with respect to leukemia and lymphoma, if you change the diagnosis even slightly, the entire answer of the LAQ will be different. So I want you to 100% nail the diagnosis. These are the common things which can come. We have 4 leukemias: ALL, AML, CML, CLL. CML we know, CLL we know, ALL we know. AML is very, very random things. Fine. Great, Rishan. Fine. Then we have Hodgkin's lymphoma, non-Hodgkin's lymphoma. Hodgkin's lymphoma and non-Hodgkin's lymphoma clinically is going to be generalized lymphadenopathy. What will help me is microscopy. Hodgkin's, you know that outside appearance, classical RSL or an RS variant you have, it's Hodgkin's lymphoma. Fine. Okay. Those are simple clues for you to identify. Just let's complete this before we go on to the next one. Whenever you have a question on Hodgkin's lymphoma, can anyone tell me what could be the most probable difference clinically with respect to Hodgkin's versus non-Hodgkin's? Like, I'll give you a clue. One of them will involve more of the Valdes ring. One of them will involve more of the extranodal involvement. Which will have more extranodal involvement? Which will have more Valdes ring involvement? What do you think? Hodgkin's or non-Hodgkin's? Which you think will have more extranodal and Valdes ring involvement? When I say extranodal, I'm talking about your GIT, spleen, of that sort. Mesenteric nodes, Valdes rings are rarely involved in Hodgkin's. Extranodal presentation are rarely involved in Hodgkin's. Do you remember them? It's just pure generalized lymphadenopathy almost always, right? Mesenteric, it doesn't go beyond lymph nodes. Valdeia and extranodal are rare in case of Hodgkin's lymphoma. It's a bit more common in case of a non-Hodgkin's lymphoma, right? Perfect. Everything is for non-Hodgkin's lymphoma, right? Easier way to remember is we read about mantle cell lymphoma, intestinal polyposis, right? We read about Burkitt's lymphoma, intussusception. DLB cell can come in the brain. We never read Hodgkin's in that manner. Hodgkin's is predominantly lymphadenopathy, fine? Perfect, Vinay, with respect to your IHC, right? So this is just a screenshot of just in the last day before the exam. Just look at this and make sure you know the key points along, right? So now let's go to the template. Template is pretty simple. If it's a leukemia, I want to concentrate more on the mutation. If it's a lymphoma, especially Hodgkin's and non-Hodgkin's, uh, pre-germinal center, germinal center, post-germinal center will make sense for us, right? And history, like I said, these are the general history. Leukemia, very non-specific symptom, which is anemia-related, pancytopenia-related symptoms. There are few specific symptoms we'll see for sure. We'll talk about pathogenesis, not in detail for ALL, AML, because a very weird pathogenesis, not a very exact pathogenesis. For lymphoma, most of them we have an exact pathogenesis. Peripheral smear, if it's a leukemia, lymph node, if it's a lymphoma. And you know one word which can go for every lymphoma. Anyone, what is the word? For every lymphoma, I'll see this microscopy. See, these are templates. Even you know nothing, you can write this. Effaced lymphoid architecture. No one will say wrong. No one can say it's wrong. For every lymphoma, effaced lymphoid architecture will be there. That's a common finding for any lymphoma. Hodgkin's, non-Hodgkin's will obviously be there, right? And obviously, we need to know the CD markers. Okay. CD markers also, I'll be more than happy if you write every CD marker, but if you write the exact CD marker, that also is enough for me. How to write CD markers in an exam? Theory exam is different, MCQ is different. MCQ has only one, but theory exam, like when I said, it's great when I write 3-4 things, right? So can anyone tell me what is a CD B cell marker? So I'm just going to tell you how to write a CD marker for a non-Hodgkin's lymphoma and maybe for a leukemia. The 3-4 markers in parallel or tandem. B cell marker is 1920, right? Almost every non-Hodgkin's lymphoma we have read is a B cell lymphoma, right? So I can write, okay, they are positive for CD19, CD20. If you want, add CD21 also. And then you will definitely know at least one exact marker. Mantle cell lymphoma, it is cyclin D1. Bucket lymphoma, it is c-MYC. That is the diagnostic marker, right? Add that. Okay, c-MYC if I'm talking about Burkitt's lymphoma. Then if you know the origin of the non-Hodgkin's lymphoma, there are few exact markers for origin. If you take a germinal center origin, I have CD10 and BCL6. Fit into it. That's all. I have a big line of CD markers. But what is required for an MCQ point of view when you go to NEET PGs? Only c-MYC. I'm not worried about the non-specific marker. I'm worried about only one specific marker, which is c-MYC for Burkitt's. Like that, there's one marker for every lymphoma, which I want you to remember. Leukemia, same. Can I say every leukemia comes from the stem cell? It does. What is the stem cell marker? CD? What's the stem cell marker? CD? 34. Right, that's a stem cell marker. You can write for any leukemia, right? Then I have only two leukemias, right? Acute leukemias, only two I have. AML or ALL. For lymphoid, I have TDT. For myeloid, I have MPO. In addition to that, write whatever you want. If it's a BALL, CD34, TDT, 1920, like you said already. TALL, CD34, TDT, 3. That's it. Right? That's more than enough for you if you want to write 4-5 markers. But I am more concerned about, for a ALL, I'm more concerned about this. For an AML, I'm more concerned about this. That's all, right? Okay. So we know how to write markers for an exam. In a Viva, please start with the most relevant marker. I really don't want to tell you to tell CD19 positive, 20 positive in Burkitt's. I'm looking for c-MYC in the Viva. If you say c-MYC, I'm happy. Examiner also will be happy, right? Perfect. Now let's go to ALL. Same template. Let's go to one by one leukemias easily and simply. I want you guys to interact. Very simple. RBC and WBC are the most easiest of all. You can revise everything within less than half an hour. Both RBC and WBC, half an hour is more than enough for us, right? ALL. Like every other cancer, I write these two things: sporadic etiology, syndromic etiology. If it's a 5-mark question, just write just the etiology alone. If it's a long answer, you can actually write the pathogenesis for everything. You know how ionizing radiation results in cancer? Yes, it can cause thymine dimers, it can cause mutation, right? This actually causes pyrimidine dimers. You know that? If in a pathogenesis, you can write this. It causes pyrimidine dimers, it causes or predisposes to mutation. You know alkylating agents, how they cause cancer, right? Same way, they are carcinogenic by default. Benzene, they are carcinogenic by default, right? Fanconi anemia, ataxia telangiectasia, right? These are all DNA repair defects. Bloom syndrome, whatever you can write. There is more amount of DNA repair defects happening, and since stem cell or the bone marrow is a highly proliferating cell, I do need DNA repairs to happen. If there's a DNA repair defect, obviously it will predispose us to mutations, right? That's all. So this same etiology you can write for AML also. Maybe a little bit of additional two findings. We'll talk about it when you come to AML. Fine. Okay. Now when you come to pathogenesis, whatever it may be, it could be a sporadic cause or it could be a syndromic cause. Both of them is going to increase the chance of mutations in a stem cell, because stem cell is something which is very rapidly proliferative. So stem cell is something which is going to undergo mutation, right? If you want, you can write specifically lymphoid stem cell, because I'm looking into ALL. If it's a myeloid stem cell, you can say AML myeloid stem cell, right? So here, what are the types of ALL you guys know? There are two different types of ALL. There are many mutations which can happen, including Philadelphia chromosome can happen in ALL, right? But I'm not worried about that. I want again one mutation for ALL B, one mutation for ALL T type, right? So when you have mutations, so there's a possibility that I can have a PAX5 mutation. PAX5 mutation results in what type of leukemia? Great. TS, you're amazing. You said everything. At least I want you to remember one. PAX5, E2A, and EBF. Those are my transcription factors, but at least PAX5 mutation, remember for BALL, and at least one mutation. What for? Notch. Great. Notch 1 mutation for TALL. Okay. Notch is also a transcription factor. Notch helps in normal function of notch is to tell which direction the cell should go. Be it a skin cell or like my hands are like this. Notch told it should be like this. Otherwise, it will be like this, right? So like that, notch gives me the direction. Notch tells you are a lymphoid cell, go to T cell lineage. So when there's a mutation there, it's going to produce more and more amount of T cells, fine? Okay, these are basic to remember. If you can remember more, great. But if you can remember this, more than enough for me, right? So I know the pathogenesis, I know a little bit about the etiology as well. Clinical features. First and the foremost thing, you cannot miss this, because leukemia, ALL, is the most common malignancy in children. It's the most common cancer across everything, fine? Sure, Safar, you can. Okay. Lymphadenopathy will be the classical history in case of an BALL, mediastinal involvement, or a thymic mass. Okay. This can be a classical finding in case of an TALL, right? Thymic mass, obviously T stands for thymus dependent lymphocytes, will be for TALL. And obviously everywhere you'll have features of bone marrow failure. When I say bone marrow failure, I mean reduced hemoglobin, reduced WBC, normal WBC, not the leukemia here, fine? Ionizing radiation causes every cancer, right, Rishank? Skin ionizing radiation, it can cause squamous cell carcinoma, basal cell carcinoma, right? Ionizing radiation is known to cause mutation. If the mutation affects my bone marrow, it will cause leukemia, that's all. And reduced platelets. It can be fatigue, weakness, could be recurrent infections. Most of the kids present to the OPD with fever or rashes. Could be a rash or even could be a bleeding gums. Fine, I have two sets of findings. See, whenever you're writing an exam, please always write the specific finding first, because the examiner's attention when there's a heading will be more concentrated on the first two lines. If you write in the first two lines, fatigue, recurrent infections, bleeding gums, like this talking story. Write this first, grab the attention, let them put the mark. This is to increase the page, that's all. Because it's very non-specific. Fatigue, fever, rash will also be there in a dengue fever. Right? It's very non-specific, but these are more specific for me, fine? Okay. Tomorrow we'll go to neoplasia. Okay. Let's go to CBCs. CBC is complete blood count. You can write all the features that anemia will be, hemoglobin will be reduced, platelet will be reduced. But what I'm looking for here is leukocytosis, whether be elevated WBC count. Most of them are with blast. Very rarely you can write this also. Rarely you also can have pancytopenia. When you have pancytopenia, most likely it will be an leukemic leukemia. This is for your extra marks because there is a possibility that ALL, all the blast can stay inside the bone marrow, not letting anything come outside. It's an aleukemic leukemia. Rarely it can present as aleukemic leukemia also or a subleukemic leukemia also. But predominantly, 99% of the time, they're going to present with leukocytosis only with increase in number of blasts. Fine. So when you come to peripheral smear, the first word I'm going to see lymphoblast. So obviously, the next line should be what is a lymphoblast? We already read in our lectures, there is a very easy way to know what's a lymphoblast, right? First, what's the size of the blast? Smaller or bigger? Definitely bigger. Nuclear cytoplasmic ratio, more or less? Undoubtedly more. Very thin rim of cytoplasm, right? Yes, yes. Will that be a granular cytoplasm? A granular cytoplasm. There'll be a great, there'll be an a granular cytoplasm, right? So a lymphoblast will be 2 to 3 times size of an RBC with a high NC ratio. I am not going with the nucleus and the nucleoli because it's always a confusion. It will be difficult for you to remember. So high NC ratio, very thin rim of cytoplasm, thin rim of a granular cytoplasm. Okay, that's a complete description of what I look for a lymphoblast. Yeah, you can write that there'll be leukocytosis with neutropenia because the normal WBC count will be reduced and be replaced by blast, right? Okay. Peripheral smear as well as in the CBC, since in acute leukemia, I want one more finding to be written. Blast should be there and it should be more than or equal to 20%. That's a criteria for me to call it an acute leukemia, right? At that peripheral smear, I have lymphoblast and the number of lymphoblasts should be undoubtedly more than or equal to 20% should be there, right? So should I draw a diagram? It'll be great if you draw a diagram. Is it difficult to draw a diagram? Not at all. See, the easiest thing what you can do for a diagram is the field of the microscope. Make it smaller. So you not waste time for the diagram. Square or circle, whatever you do, right? Draw an RBC. 4, 5 RBCs, simple. Draw one blast. First thing, 2 to 3 times size of an RBC. High NC ratio. Make it like this. That's it, enough. That's all. Mark this lymphoblast if you want. Or write it's a blast. Okay. For a myeloblast, just put a line or rod. Easier to draw. Very simple descriptive diagrams, need not be artistic. The clue is don't put such a big square or a big circle. You have to fill in lot of things. It'll be difficult for you to manage the time. Draw smaller field, easy to represent only one feature. You want to represent a papillary carcinoma thyroid? Put a papillae and lined by orphan Annie eye nuclei. That's enough for me, right? A fibrovascular core lined by orphan Annie eye nuclei, clear side nuclear, that's all. When it's smaller, it's much easier for you to fill it with the content what is required for us. Fine, let's go to this. The older way of classification, we had L1, L2 and L3 blasts. In this current era, we don't have L1, L2, L3, but it's also fine to represent L1, L2, L3 because most of the examiners will want it, right? L1 is more of an homogeneous blast. When I say homogeneous, all of them look almost similar. They are a little bit smaller and they have a good prognosis. Before onset of genetics, I am looking at the prognosis of the appearance of the blast. L2, they are heterogeneous population. When I say heterogeneous population, they'll be smaller and bigger blast. So it'll look asymmetrical. Not everything will be same, one will be bigger, one will be smaller. And they have most often intermediate prognosis. L3 is Burkitt's blast. It's actually not a ALL, it's a Burkitt's lymphoma going into the bone marrow and coming out. So that's a Burkitt blast. Burkitt blast has a very characteristic appearance. Again, high NC ratio, draw the nucleus. The cytoplasm should be sky blue. Along with that, you'll have vacuoles in the cytoplasm. That's classical for Burkitt's blast. You have a sky blue cytoplasm plus vacuoles in the cytoplasm. Fine. And a very important thing about Burkitt's blast, they are SBB positive, and PAS negative. Please mention this because that's the only reason I want you to know Burkitt's blast. Fine. Okay. Fine. They won't ban it, right? It's French, American, British. It'll be there, but we don't use it anymore. Let's not worry about it. Fine. L1 and L2, L3. There's an old French, American, Britain classification. Fine. Okay. Now let's go to investigation. How will I proceed and how will I approach a case of leukemia, right? We can write it as an approach to leukemia as a heading, but what I want you to remember is always investigation of choice is flow cytometry. Fine. The reason why it's PAS negative is PAS is a storage form of sugar, right? Glycogen is positive for PAS. Since Burkitt blasts, if you remember Burkitt's lymphoma, they have 100% Ki67. They are constantly dividing. They use all the energy. So there is no stored energy. That's why it's PAS negative. Fine. Okay. Great. So an approach to leukemia. So let's say clinically and CBC wise, there is more amount of WBC. And let's say PS shows more than or equal to 20% blast. And one more possibility, PS shows less than 20% blast. Okay, this also is possible, right? In subleukemic and aleukemic leukemia, right? So here, what I do is, I go directly with markers. What could be the markers? Simple markers, they are always PAS positive. For this, what's the next route? For the peripheral smear having less than 20% blast, what's the next route? Then if PA is positive, I'm a little bit convinced. It's not the investigation of choice. Investigation of choice will always only one guy, flow cytometry. Okay, PAS is an immunocytochemistry. If it's less than 20%, like someone said, you have to go for a bone marrow aspirate or a bone marrow examination. If there is more than 20% peripheral smear, it's enough for me. Then again, it will come to the same route only. It will come to flow cytometry only. If PS shows less blast, bone marrow, then flow. If PS shows more blast, adequate blast to call it an acute lymphoid leukemia or an acute leukemia, directly markers and flow. So what do I see in flow cytometries? CD markers primarily. That's all, right? So I have two types of ALL, BALL and TALL. Both of them are leukemias. They originate from the stem cells. Fine. So you have CD34 positive. Both of them are lymphoid leukemias, right? So both of them are TDT positive. This is for lymphoid precursor. One is B lymphoid leukemia, so they are 19 and 20 positive. The other is T lymphoid leukemia, so they are CD3 positive. T cells 1 to 8, all of them are positive, but 3 is more accurate, right? It's simple. I read them repeatedly, so you won't forget 34 and TDT, and 19 and 20 and 3 also you will not forget it, right? Reason for L3 means, Rishank, they initially thought Burkitt's lymphoma also is a blast, so they put it as L3. Since they didn't have OR rods, they put it as lymphoid blast in FAB classification, right? Okay, so it's the approach for ALL. Write it as approach, and investigation choice by default is flow cytometry. That's all, right? So once I have diagnosed, the next thing left for me is prognosis, right? Prognosis, good and bad. Remember only one thing. This is just for an exam purpose. Write poor if it is not in good. Try to remember good. It's a tumor of children, right? So 2 to 10 years, good prognosis. Less than 2 year or in infancy or more than 10 year, bad prognosis. Gender, women, good prognosis. And whites, good prognosis. White is more of access to healthcare. Men or boys, they are children, so let's use the term boys and girls. Boys and blacks and Afro-Americans, bad prognosis. Fine. Okay. I told you the reason why boys have bad prognosis, because of testicular involvement. They are difficult to chemotherapy to go into the testes because of the blood testis barrier. Fine. Rishank, there are subcategories of pre-B, pro-B, pro-ALL, B-ALL and everything. Again, for undergrads, you need not go into the depths of it. This is more than enough for you, fine. WBC count of less than 50,000 per cubic mm. Good prognosis, telling the tumor load is less. More than 50,000 to 1 lakh per cubic mm. More bad prognosis, telling the tumor load is more. CNS testicular involvement absent. a good prognosis, present a bad prognosis because of blood testis barrier and blood brain barrier. These are chemo resistant sites. You can write this also in the corner, so the examiner knows that you know why they are bad, because it cannot cross the testis barrier and blood brain barrier, so chemotherapy resistant. So when I stop chemotherapy or I go into maintenance mode, the blast will come back and there'll be a recurrence. That's all fine. Cytogenetics, you have lots of trisomy 4, 11. Okay, that's a good prognostic thing. Bad is if I have a cytogenetics which is not seen in ALL, that's your 922. And also we have always had this template, hyperdiploidy, a good prognosis because they are very unstable, so it breaks easily. Right? Access to healthcare, Ipshita, that's all. In the US, whites have more access to healthcare because of the economy. That's why when all the studies come, it becomes a good and bad prognosis. Fine. Treatment response, the blast disappear from the blood or from peripheral smear after 1 week of chemotherapy. A very good prognosis. Blasts are persistent even after 28 days, the worst outcome. Even after completing 28 days of chemotherapy, if the blast is going to stay there, definitely worst outcome, right? You can write the treatment option, whatever Siraj has taught you in pharmacology. I am not going into the drug options. You know it better than me, fine? T cell is bad because T cell, the notch mutation causes more tumor burden. The T cell leukocyte count, CBC count will be generally in lakhs, 1 to 2 lakhs. Because of the tumor burden per se, T cell has a bad prognosis, B cell has a good prognosis, fine? That also you can write to this, fine? Okay, that's with your acute lymphoid leukemias, fine? A simple thing. We're going to do the same for acute myeloid leukemia also. Etiology will remain the same. Pathogenesis is where in acute myeloid leukemia, we'll use your WHO classification, right? Pure, see you next year. Okay. Then we'll have the clinical features, same, little bit here and there. Okay. Then we have the CBC, peripheral smear. We have different types of blast in AML, different features in AML and different markers in AML for each of the blast. And we have the same investigation protocol plus more than 20%, go with the same markers, go with flow. Less than 20%, go with bone marrow, go with flow, right? Prognosis is actually based on the classification. So that will be done in the single go, okay? Now let's come to AML, acute myeloid leukemia. Same sporadic, same syndromic. Ionizing radiations, drugs, chemicals, benzene can definitely cause chemotherapy. Sorry, can cause AML. What is added here is Leaf-Romney syndrome. I've added a little bit because Leaf-Romney syndrome has more predilection towards AML than in ALL. Second, these two. PNH and myelodysplastic syndrome causes more of AML. See, myelodysplastic syndrome, more of a myeloid blast, right? It can also cause ALL, very unlikely. PNH, again, there's a problem in the myeloid stem cell because if you remember PNH, RBC, WBC platelets, all of them gets affected. So myeloid lineage mostly, right? That also can cause. Very rarely, CML can also cause. Blast crisis, that also can cause, right? So it's an acquired disease which can also predispose to AML, right? So classification as per the WHO is actually the pathogenesis. There's the latest WHO classification, very simple to remember. We had these three to remember in a different way. Can anyone tell me what is common for all these three? Because these three are very, very important. AML with recurrent cytogenetic aberration. I will see this almost always in leukemia. That's why these three were exception for the blast percentage. If I see these three, I don't want 20% blast. I can still call it an acute myeloid leukemia. Don't forget that. These three are very, very important for us, right? And this is what you also see in APML. Okay. This, whenever the translocation involving 11th chromosome comes, it always carries a worst prognosis because this again will be resistant to chemotherapy. And they'll have a worst or the bad prognosis, right? Okay, perfect. And AML with normal cytogenetics, mutated NPM1, FLT3 are newer ones. If you miss it also, it's okay for me. These four, don't forget, must. Then in the etiology, we wrote that MDS can cause AML, right? So if MDS becomes AML, what will be the prognosis? Already it's a cancer, becoming the second cancer. Obviously, that's the bad prognosis. Because one cancer is becoming another cancer or progressing, fine? Yes, Zafar. Okay, so with prior MDS, history of MDS or AML with multiple dysplasia. That's the definition of MDS, right? Or AML with MDS like cytogenetics. If you want to write one MDS like cytogenetics, deletion 5q. There's a very classical cytogenetics of MDS, monosomy 7. That also is a very classical cytogenetic seen in MDS, right? So if I see this, that's required. These three, the first three of the AML does not require that, the 20% blast criteria, right? And AML therapy related, these are your secondary leukemias. I'm sure you must have been thorough with chemotherapy drugs. Your topotecan, irinotecan, all of them has a risk of secondary leukemias, right? Obviously, the patient is getting chemotherapy because of a cancer. Because of that, I'm having one more leukemia. Obviously, it's a bad prognostic factor. So prognosis with respect to AML is predominantly based on genetics. That's why WHO classification is very important for me than my AML M1 to M0 to M7. Fine. I'll answer the question. The last but not least is AML not otherwise specified, right? This is your old FAB classification. We're still stuck with AML. Here we have AML M0 to AML M7. If it's a long answer, write everything. M0, M1, M2, write everything. So short answer, just mention that is AML M0 to M7 is present. You obviously will know AML M0 is AML without differentiation, undifferentiated. I don't know what type it is, right? Second, M1, M2 without maturation, with maturation. M3 is your APML, acute promyelocytic. M4 is myelo mono. M5 is pure mono. M6 is erythroid. M7 is megakaryocytic, right? So you should know how to write AML M0 to M7. M0 is undifferentiated. I don't know where it is. Lymphoid or myeloid, very early. M1 is myeloid only without maturation. When I say without maturation, it means less than 10% sites. When I say sites, mature cells. M2 with maturation. So when I say with maturation, more than 10% sites. Fine. It might not come, Rishang, might be a very rare question. Don't get stumped by the question. Questions will be simple. APML is AML M3. M4 is myelo changing to mono. So both of them. M5 is mono. M6 is erythro. M7 is megakaryo. Since myeloid precursor gives rise to all these lineage, I can have AML with all these subtypes. Fine. Rishank, AML M7 coming as a long answer is very, very, very unlikely. The examiner must be pissed off with your batch, so only they will give it. Because AML M7 even for a postgraduate, there's nothing much to write in AML M7. It's a very rare leukemia. Let's not go into it. Fine. Your exam will be simple. So once you know the classification, almost in that my pathogenesis is linked. So let's go to clinical features. Clinical features same. I have the features of bone marrow failure, features of cytopenia. I'm not repeating this. We already read in your ALL. Specific features are something which is required. APML has a specific feature. AML M4, M5 has a specific feature. AML M7 has a specific feature, right? Rashank, if at all they ask about M7, we'll read few classical points of the M7, build a story around it. That's all, fine. What is the specific feature of AML M7? AML M7, everyone. Because AML M3 you know already, or APML you know already, we discussed DIC. M4, M5, I'll use term chloroma. Chloroma means extra medullary, medulla is your bone marrow, blast is your chloroma, right? Great DS. Chloroma is extramedullary blast. This could be leukemia cutis. I can have blast in the skin. It could be in your gums. Can have gum hypertrophy. It can also be in your retroorbital tissue. When it's there in retroorbital tissue, it can cause proptosis. Proptosis, in thyroid you must have seen, right? Proptosis. Because of the blast going and sitting in very, very, very rare places. All this could be for AML M4 and M5. AML M7, like TS said, can present with myelofibrosis. Okay, which means the patient will present with massively enlarged spleen. Since we are in clinical finding, I have to write the clinical terminology. Or a vague left hypochondrial pain. Massive splenomegaly, vague left hypochondrial pain. If it's a leukemia, think of this. On Downs. One of the AML, which is more common in Down syndrome patients, is AML M7, right? So these are specific. Again, like I said, write specific first, non-specific later, so that you'll catch the eye of the examiner. That's all. Obviously, most of the AMLs, that is AML M2 is the most common subtype, will present as non-specific symptom only. When you take a CBC, I know, okay, this patient is most likely suffering from your acute leukemia. CBC same. I have leukocytosis. Not always. You can also have leukopenia or cytopenia. It's not as rare as seen in ALL. I can have both leukocytosis and leukopenia. APML always presents as leukopenia only or cytopenia. That's why it presents as DAC. Fine. Okay. Same reason, Rishank. The blast goes and presents a retroorbital tissue. It pushes the eyeball front. Like gums becoming bigger, retroorbital tissue becoming bigger. That's all. Fine. Okay. And obviously, the blast should be more than or equal to 20% in the peripheral smear or in the bone marrow. Okay. But there's an exception to the blast criteria. Exception for the blast criteria, if you have the first tree translocation 821, translocation 1517, or an inversion 16, or a translocation 1616. All these are exceptions. When you have any of these, there is no need for 20% blast. I can even call it an acute myeloid leukemia with a 10% blast if I have any of these three cytogenetics, right? That's how it is, right? So now let's come to peripheral smear. We'll see few classical features to tell you an exam for myelo, for M3, M4, M6, and M7. Fine? Okay? Okay? Perfect. So let's go to myelo. Classical myeloblast, same. 2 to 3 times of an RBC. See, these are standard for any blast. 2 to 3 times RBC, high NC ratio. This you can write for every blast. I'm not going to repeat this for every other blast, but you can write this for every blast. What's the classical finding? So in the cytoplasm, there are multiple classical findings to call it a myeloblast. One, I can have granules, right? Second, you can have OR rods. OR rods are also nothing but same azurophilic granules only. They are also same granules, but in the form of a rod, that's all. No, Rishank, I meant leukopenia only. Leukocytosis or leukopenia, because APML, which is one of the subtypes, will have leukopenia. They can present with leukopenia because blast will get stuck in the bone marrow. They don't come outside. Fine. Or there's something called as Phi body. Phi body is also same azurophilic granules, but very dense granule. That's all, right? They are very dense granule. Fine. You can draw a diagram, put a high NC ratio, give a little bit of more cytoplasm here because you have to draw an OR rod. These are how OR rods will be, and this is how Phi body will be, and these are granules. All these three you can mention. Okay, there's a granule here, there's a Phi body here, and there's an OR rod here. Just a diagrammatic representation if you feel your exam paper should be colorful to get good marks. Some examiners also feel that. Let's put that in the perspective. Fine. Okay, that's for myeloblast. So you have AML M3. There are two important findings in AML M3. What are they? Anyone? High NC ratio will be there. 2 to 3 times of RBC will be there. I'm not repeating it. They're always there, right? Two things with AML M3. You have a buttock-shaped nuclei or a folded nuclei. That's very classical. And we have faggot cells. Faggot cells are dense bundles of OR rod. They are dense bundles of OR rod. Again, the way to draw them is very simple. It's buttock shape or folded, right? Folded, that's all. That's a buttock shaped nuclei. And bundles of OR rod. Not one, I'll have lots of OR rod. It's very easy to draw multiple lines here. Bundles of OR rod, that's your faggot cell, and classical for AML M3. M4 as well as M5, my concern here is monoblast. I can have monoblast or write the term promonocytes. That's also considered as a blast equivalent, whatever it may be. What is the shape of monocyte nuclei? Normal monocyte. That will be here as well. I have kidney shaped nuclei. And one important type of chromatin called as lace. Lace-like chromatin. They're like a sieve. They're not very dark chromatin, like a sieve-like chromatin, right? That will be here. So it's up to you. How do you differentiate a kidney versus a buttock-shaped nuclei, right? The buttock-shaped nuclei will have much folding. Kidney shape will not have that much folding. And it's lace-like chromatin. It will not be very, very, very dark. It will be very thin like a lace. That's a lace-like chromatin. This obviously will be a little bit more darker, fine? Okay. That's a lace-like chromatin, kidney-shaped nuclei for a monoblast. Draw the kidney a little bit bigger, should have high NC ratio. Yeah. AML M3, what we have is promyelocyte only. So whatever we have in AML M3 is promyelocyte. Because AML M3 comes in the exception of the 20% blast criteria. We won't have blast in AML M3, fine? Okay. You're right, TS. AML M6, you'll have very, very, very round nuclei. The most important thing in AML M6 is the classical blue cytoplasm. Because if you look at erythroid blast, if you remember our discussion of erythropoiesis, the cytoplasm is what gives away, right? The basophilic, polychromatophilic, orthochromatic cytoplasm. Cytoplasm is very, very characteristic. In addition to that, I'll have an exact round nuclei. That's for an erythroblast. Fine. Okay. AML M7 will have your vacuolations, cytoplasmic bleb. That's very, very classical. These are reminiscence of the platelets being formed, and this will have almost negligible, very, very, very thin cytoplasm. It look like a fragment of a blast, not like a blast, right? So when you're drawing AML M7, don't draw cytoplasm. Almost entire thing should be the nucleus. Very thin cytoplasm, but draw tiny blebs. These are the platelets which are being formed. That's a classical appearance of an AML M7, right? So this is the appearance of all the blasts seen in leukemia myeloid, fine? Normal blast, M3, promyelocyte like Roshan said, and you have M4, M5, M6 and M7, fine? Great. I've not talked about markers yet. We'll look at the markers soon. Markers always comes in the approach. Okay, why does squamous cell carcinoma produce keratin? That's also a mature squamous cell function, right? That's how they'll be. Okay, perfect. Let's go to flow cytometry and approach, right? So here is about approach. So approach is same like we did for your acute lymphoid leukemia. CBC, more than or equal to 20% blast, less than or 20% blast, then you do a bone marrow aspiration. So here I go directly for markers. The first line is markers, second line is CD markers. CD markers can be done by flow cytometry. So markers, MPO is a classical myeloid marker. Like TS said, NSC. There are two NSCs in pathology. This is non-specific esterase. Non-specific esterase is positive for monocytes. PAS with a cytoplasmic blush. This is important. If you cannot write or don't remember cytoplasmic blush, please don't write it. This is for M6 because PAS is positive in lymphoid blast, but cytoplasmic blush for AML M6. Same PAS, granular and diffuse for M7. Again, if you cannot write granular and diffuse, ignore it. Okay, I don't want you to write a mistake. If you don't know, ignore. Stop with this. That should be more than enough. That's my first layer. Next layer is obviously your investigation of choice, your CD markers with respect to flow. Fine. Okay. The approach is same. Can I say almost every leukemia will be CD34 positive? They'll be, except one leukemia, which is APML, because APML is your promyelocytic, right? So every leukemia, every AML is CD34 positive. You can write that except APML, which is CD34 negative, or your AML M3, right? Because that is coming from promyelocytic site, not a blast, fine? Then I don't say AML M1, M0, M1, M2, M3 does not have a difference in microscopy. It's a difference in IHC. It's a difference in your microscopy only, right? So every AML from AML M1, M2, M3, all of them will be MPO positive. If I want a CD marker, 1333 positive. Fine. No, it's the origin. Origin determines whether it becomes M6 or M5. If it's coming from the erythroid origin, we know that it committed erythroid cells and it becomes M6. Fine. Okay. AML M4 and M5, the markers are CD14, CD64. Okay. AML M6, it's erythroid, hemoglobin A. If you can remember one more protein, glycophorin. Glycophorin is also an RBC protein. AML M7, CD41, 61. These are nothing but your glycoprotein 2B3A, the platelet molecules which helps in the thrombosis, right? This is for your CD markers. But this should be more than enough to say it's an acute myeloid leukemia. For my subtypes, yes, I would want all of the markers to be there, fine? Okay, that tells your entire acute myeloid leukemia workflow. We know the microscopy, we know the clinical features, we know the subtypes. Subtypes tell me the prognosis, so need not write the separate prognosis. The best prognosis of all is your APML. These are good prognosis. Rest everything is bad prognostic factor, right? And also we know the etiopathogenesis, right? That's with respect to your acute myeloid leukemias. Okay. Okay, got it? Perfect. Let's go to lymphomas. Any doubt in leukemias? If you have a question in leukemia, please don't misdiagnose it. Please remember the main difference between ALL and AML, one is the blast or rod. Before that, age. A leukemia in a child has to be an ALL. Unless it is a Down syndrome, I can think of an AML-M7. Otherwise, it has to be an ALL, right? For every lymphoma, I'm considering CLL as a lymphoma because it comes under lymphoma only, right? Non-Hodgkin's lymphoma. Origin, pathogenesis, history will almost be same. So I will not repeat generalized lymphadenopathy. Most of them are in adults except Burkitt. So adult generalized lymphadenopathy, you have to write for everything. If there's any specific finding, I'll tell. Peripheral smear, if it's required, lymph node is required. Look at the image, then markers, prognosis. They will come most likely in your short answer. Very, very unlikely to ask in a long answer. 1, 2, 3, 7 headings is more than enough for a short answer. And if you write correct points, 1 for every 7 headings, I'll be more than happy. The examiner also will be more than happy, right? So origin of your CLL is your naive B cell. Okay, it's a naive B cell or a pre-germinal center B cell. If you have to classify into germinal center, pre-germinal center B cell, right? So there is CLL bar SLL because SLL has a different origin, post-germinal center, but predominant is going to be CLL, right? So mutation wise, there are lots of mutations, but what ultimately happens is CD5 will become more. Whenever there's more CD5, it increases your Bruton's tyrosine kinase. That increases your cell division or cell proliferation. Okay, that's what actually causes CLL, right? That's why if you remember in your pharmacology, there's a drug called as an ibrutinib, which blocks Bruton's tyrosine kinase. If you can write right here, ibrutinib blocks Bruton's tyrosine kinase, like your imatinib, so helpful in CLL. History, like I said, 2 things are important: adult and generalized lymphadenopathy. Classical findings for CLL. CLL is one thing which will definitely be involving other lineage of the other lineage of the blood. It can cause autoimmune hemolytic anemia. It can cause ITP, right? So this results in the combination of this is Evans syndrome. If you want to score more points, write this. Your CLL plus autoimmune hemolytic anemia plus ITP is your Evans syndrome. Fine. Okay. That should be enough for you for clinical symptoms. If you want to elaborate, elaborate. If it's a 10 mark, right, generalized lymphadenopathy, more than 2 non-contiguous lymph nodes involved in generalized lymphadenopathy, right, it's rubbery in texture, non-tender, non-painful, right, whatever you want. But it's a 5 mark, just write generalized lymphadenopathy. The best thing about an MBBS doctor is if you want to talk for half an hour with a simple symptom, you can do the same thing in exam. If they ask a 5 mark as a 10 mark. If you want to cut it short, think it's a viva. Nothing will come out of us, right? Peripheral smear and CBC. So obviously in CBC, you'll have leukocytosis. Not just leukocytosis, you'll have lymphocytosis. That's very, very important. Plus or minus, I can have autoimmune hemolytic anemia, hemoglobin can be reduced. In peripheral smear, what's a classical finding? Increase in the lymphocytes. These lymphocytes are mature appearing lymphocytes. They are not blast. They are mature appearing lymphocytes. That will be there. In addition to that, you'll have smudge cells. Please don't stop with smudge cells. Even if it's a short answer, explain smudge cell, because smudge cell is the diagnostic point here, right? They are nothing but they are cells which have weak cytoskeleton. So the cells with weak cytoskeleton will appear smudged on smearing. Okay. The smearing pressure will make it appear smudged. The weaker cytoskeleton is loss of Vimentin. That's the reason for smudge cells. Please do write it. It's bare minimum. I will expect why smudge cells. Fine. Lymph node. I have already told one thing. Effaced lymphoid architecture for everything, and they are replaced by small lymphoid cells. We divide lymphoma into small, medium, and large. CLL, mantle, marginal, follicular, small. All of them will be the same. Intermediate is Burkitt, but Burkitt we know starry sky. DLBCL is large, that's all. Right? Replaced uniformly by small lymphoid cells, and there is a finding called as proliferation center. Proliferation center is classical for SLL. This because lymph node will be lymphoma, not leukemia, right? Proliferation center are sites where you see pro-lymphocytes in the lymph node. The site of pro-lymphocytes in the lymph node, we call it a proliferation center, a diagnostic finding for CLL, fine? That should be more than enough. Now you will tell me the marker. We'll start with general ones, right? So can I say it's a B-cell leukemia lymphoma? It is. So obviously they are CD19 positive, 20 positive, right? It's a naive B-cell. If you remember the B-cell journey, it is CD5 positive, CD23 positive. They came before even entering into the mantle zone. They are in the periphery, just circulating. There only it became a leukemia, right? And CD5 is something which is important, the pathogenesis. More CD5, more Bruton steroid kinase. If required, write this also. CD200 is positive. It's a new flow cytometry marker, not applicable on a biopsy, but I can use it on a flow cytometry. It's very, very important, right? This must to know. You will all remember. This also you'll remember. Please also, if possible, just look at the notes of B-cell journey the day before the exam. So even if you forget, you can identify and trace where they came from. You'll be able to answer something, fine? Okay. Prognosis or complication, lots of things, but one thing is very, very important. CLL is a leukemia. I cannot say it a lymphoma, right? Because we say lymphoma or leukemia based on origin, because origin is naive B cell, which are lymphocytes. SLL is a lymphoma, fine? The only one thing which I'm looking for is CLL transforming to DLBCL. So I'll suspect this when there's a painful, sudden increase in size of the lymph node. I'll suspect it. And we call this an what transformation? Richter's transformation or Richter's syndrome. Okay. We call it Richter's transformation or Richter's syndrome, which makes us understand, okay, it's a DLBCL. Okay. Got it? Fine. So simple 8 points, 7 headings, 1 or 2 significant points for the heading should be more than enough for an exam. But please don't forget these headings. Origin is required. Mutation and pathogen is always interlinked. History, one or two classical findings, one or two template findings. Peripheral smear, if required, right. For the rest of the lymphoma, we won't have peripheral smear because they don't involve peripheral smear. CLL will involve. Lymph node, effaced lymphoid architecture, small or intermediate or large, you already know. Remember one more thing, that's all. Marker, most of them are B cell tumors. 1920, you already know. Please write the pathogenic marker next. That's enough. BCL2, your cyclin D1, CMYC for the rest of the lymphomas. More than enough, right? Then prognosis. Almost every lymphoma will progress to DLBCL. So it's a template prognosis complication. CLL can become, mantle can become, marginal can become, follicular can become. But in CLL, I gave a term, Richters. In other places, I don't give a term. That's all, fine? Let's go to mantle. Mantle, our easy way to remember is mantle. 11. Looks like 11, right? So my origin here is, this also is a pre-germinal centered neoplasm. Fine. Its translocation between 11 and 14. We know why 14. 14 is immunoglobulin H, which is always constant for everything, which results in cyclin D1 translocation with immunoglobulin heavy chain. This results in activation of cyclin D1. When cyclin D1 is active, go back to our cell cycle. This increases more and more and G1 to S transition. Whenever something moves from G1 to S transition, which will obviously increase my proliferation, which causes tumors. Simple. History, adult generalized lymphadenopathy will be there. The non-Hodgkin's lymphoma. So extranodal is common, right? This can also have an extranodal presentation, which is very, very classical. You have something called an lymphomatoid polyposis. This can present as polyps in the intestine, looking like a familial adenomatous polyposis. So we call it lymphomatoid polyposis. Must. Don't forget it. Because it's something which I'll require. Rest everything is non-specific. I cannot say it is not CLL by generalized lymphadenopathy. But this can tell me, okay, most likely a mantle cell lymphoma, right? Peripheral smear will not be there in mantle. We have lymphoid, a lymph node. Again, effaced lymphoid architecture by small lymphocytes, replaced by small lymphocytes because there's also small lymphoid neoplasm. But classical early finding is expanded mantle zone. Initially, it will be expanded mantle zone. Normal mantle zone will be 2-4 layers. Here it will become very, very thick. If you want to draw a diagram, again, it's simple to explain in the form of a diagram. Just draw as germinal center, normal mantle. So what do we mean by expanded mantle? Again, a germinal center and an expanded mantle. See, it's simple to represent. It will not be difficult. If you want to be artistic, yes, it will be difficult. If I just have to represent, okay, this is what expanded mantle looks like, I can easily represent how an expanded mantle looks like, fine. I'm not able to understand, Rishan. Let me explain it better. I'll help you. Fine. Marcus. So Marcus, this is also the B cell tumor, 1920 positive. This is also pre-germinal center tumor, so it's CD5 positive. But once it enters mantle zone, 23 will be knocked off, 23 will be negative. But what is more important for me is cyclin D1 positivity. There is a subset of mantle, very rarely, cyclin D1 negative mantles. This we read for an MCQ point of view. There will be SOX11 positive. Okay, that's for my marker profile. Okay, CD5 is positive. It's not extremely positive, right? BCL2 has positivity and neoplastic positivity. So here CD5 will be positive, not mutated. Cyclin D1 is mutated. Fine. Okay. Prognosis complication. Again, like I said, any small lymphoid neoplasm can become DLBCL. That's a possibility. Again, there's a variant of mantle with P53 loss. Makes it aggressive. We call it an blastoid mantle cell lymphoma, which has the worst prognosis. Fine. That's for your complication and your prognosis. Got it? Fine. Let's go to the next lymphoma. Same way for follicular. Same 6-7 headings, more than enough. Follicular is what origin? Pre-germinal center, germinal center, or post-germinal center? It is germinal center origin. Follicular. 14 is same. Translocation between 14 and 18, right? So because of this problem, 14 and 18, there's an excess, or we can write, if you want, BCL2 with same immunoglobulin heavy chain. Because of this, solved one TS, it will be then the Telegram group of PW. It will be in the pinned comments, or it will be below the description. Fine. Okay. See, normally, Rishank, normally only the mantle zones will be positive, right? Momentarily positive in a normal lymph node. But when you take in an mantle cell lymphoma, it's effaced architecture. Everything will be cyclin D1 positive. That's how we'll identify it. Fine. Okay. So there'll be excess of BCL2. We know that BCL2 is an anti-apoptotic gene. So more of anti-apoptosis, they don't die. So they live for a long time, which can add new mutations, which can make them cancerous. Okay, that's the simplest pathogenesis for your follicular lymphoma, right? So if at all you want to write what could be the new mutation, there's a possibility you can write it, but if you forget it, stop it here. If you want, write the new mutation which is most likely important for mantle cell lymphomas, KMT2D. It's a transcription factor. It's there in Roberts. If required, write it. Otherwise, write new mutations resulting in a follicular lymphoma. That should be more than enough, right? Okay. History, same. Adult generalized lymphadenopathy. One classical for follicular lymphomas, it's a very indolent lymphoma. Very slow growing lymphoma. So what happens is these patients will have history of lymphadenopathy for years. Like 5 years, 6 years, because it slows very slowly. It grows very slowly, right? That's how it is, right? See you soon, Amrut, in the second year. What I'll see in lymph node, same. Effaced lymphoid architecture by small lymphoid cells. That's the last. That's a follicular lymphoma. You can write it, right? You'll have increased follicles in both cortex and medulla, and there'll be very almost nil or reduced interfollicular area, right? That makes it a follicular lymphoma, right? If you want to draw a diagram like this. Put a round lymph node, draw everywhere round follicles. It's just representative. Doesn't make any sense. Honestly, it doesn't make sense, right? So more number of follicles in a microscope if you want to draw a diagram, right? Extremely high follicles, both in cortex and medulla, very less interfollicular area, classical of follicular lymphoma. How am I going to confirm? Markers. Same, start with same. They are B cell tumors. They come from germinal center. When they come from germinal center, we have CD10, BCL6 positive. These are GC markers. Any tumor which comes from germinal center, write this. They'll be positive for sure. Burkitt's also will be positive, right? But what is more important for me is this guy. And also write this. Ki67 is low because I told it's an indolent lymphoma. They'll have low Ki or low proliferation. That's very classical for follicular lymphoma as well. Fine. These two are important, specific for the tumor. Perfect. Prognosis. Same. Follicular lymphoma can also go to DLBCL. That's template. And one problem of follicular lymphoma being indolent, slow growing. So 2/3 of patients, because of the slow growing, they don't come to a doctor and they present with bone marrow involvement. And in the bone marrow, they have a very classical pattern. In bone marrow biopsy, you will see paratrabecular involvement. This is very classical for follicular lymphoma. You have to mention this is required. Fine. So DLBCL is a template, but this is unique. For CLL, DLBCL is a template, Richter is unique. For a mantle, DLBCL is a template, blastoid mantle is unique, right? So write this, that should be more than enough. Same template, repeat it. Okay, let's go to Burkitt's. Same template, let's repeat it. You'll tell me, Burkitt's is pre-germinal, germinal or your postgerminal. Burkitt is coming from the, it's also a germinal centro origin. If you want to be very specific, centroblast origin. Not a centrocyte, centroblast origin, right? Pathogenesis, it's always Burke 8, right? If you want to write that, it's Burke 8 lymphoma, right? So translocation between 8-14, which is the most common translocation, but please don't stop with that. Translocation with 2-8 or translocation with 8-22 also can happen. Whatever may be the translocation, my only concern is 8. 8 becomes more. 8 is where I have c-MYC. Increased CMYC. Increased CMYC gives stemness to a cell. It gives the capacity to behave like a stem cell. We call it stemness to a cell, to any cell, which means it indirectly increases Warburg's effect. Because the more Warburg, obviously it will definitely keep on dividing, more cell division, which results in a Burkitt's lymphoma. It's a very, very aggressive tumor, right? History, don't go with the template. It's not a tumor seen in adult. It's a tumor seen in children. Here I want the history to be different. Endemic Burkitt, a child, jaw swelling, Africa. The image what you see in every Burkitt's lymphoma Google search, first image, child with a swelling in the jaw, mandible, right? Sporadic Burkitt also is common in children, okay? It can be nodal lymphadenopathy, extranodal intussusception. I hope the spelling is right. If not, write the correct spelling. Fine. Child, nodal or extranodal, we have intussusception present in intestine. That's a classical finding, right? Lymph node, you know it. What's a finding of Burkitt's lymphoma lymph node? Something you will never forget till you die, right? Only thing you will remember after finishing pathology is starry sky appearance. If you go to your internship, you will forget everything else. The only thing you will remember is starry sky appearance. If you want to write, here also there will be an effaced lymphoid architecture by intermediate tumor cells, but will have starry sky appearance, right? Obviously, you'll have effaced lymphoid architecture. Here, the stars are the tingible body macrophages. Okay. The sky is here the tumor cell. Fine. Centrocyte and centroblast are obviously different. Blast is an immature cell, high anciation, everything. Centrocyte is a mature cell, folded nuclei with more cytoplasm. Fine. Peripheral smear can have Burkitt's blast if there is a bone marrow involvement. This indicates the bone marrow is involved. And we already read how a Burkitt's blast will be look. It looks like an, okay, it looks like your L3 blast. Fine. You have to forget, Rishank. If you remember everything, no, it's not good for you. Forgetting and rereading and memorizing is what makes you perfect. Okay, let's go to markers. Markers same, 1920. If you don't forget, I'll be very, very, very happy. PCL6, the germinal center markers. But what is more important for me is CMYC positive. And one more guy, KI67, will be 100%. Telling almost every cell will divide at any given point of time. That's very, very classical for Burkitt's lymphoma. Right? Great. Prognosis and complication. One complication I don't want you to forget. Since they are very, very highly proliferative, there's a possibility of tumor lysis syndrome. This can be spontaneous or with chemotherapy. And you know what will happen with tumor lysis syndrome? If the long answer expand, short answer just write tumor lysis syndrome. Cell will die and everything will come out. So you'll have hyperkalemia. Potassium comes out. Hyperphosphatemia because it's a buffer, right? Phosphate comes out, it will bind to calcium, which causes hypocalcemia and hyperuricemia. And obviously you'll have acid-base imbalance because bicarbonate also comes outside. I never said it involves cervical lymph node only. It's so fast from the jugular digastric destroys the entire jaw and presents a jaw swelling, right? It's very fast, that's all. So from here to spread to here, this grows fast. So they will come to the clinic soon. That's it. Okay, it'll also involve all over. Okay, that's for Burkitt's. Let's go to Hodgkin's. Okay, Hodgkin origin, germinal center, post-germinal center, pre-germinal center. What do you think? Cripple B center, right? It's a germinal center origin. The germinal center origin first, to be very specific, crippled B cell. GC origin, but a crippled B cell, right? Pathogenesis, there are two things here. Let's write B cell only, not saying crippled B cell. B cell which is about to die, which will be revived by two persons. Either an EBV, because of the EBV, I'll have nuclear factor K beta, which will revive the death and it will increase proliferation. That's why few of the Hodgkin's lymphoma variants are EBV positive, fine. And B cell, it's a B cell neoplasm, it's a mature B cell neoplasm, FAARE cell leukemia, fine. Okay, and in non-EBV related Hodgkin's lymphoma, there's a mutation of proto-oncogene called as REL proto-oncogene mutation. So REL proto-oncogene mutation, this is the same thing, it's oncogene mutation, right? Gain of function mutation, which also increases the proliferation. Ultimately, it's nuclear factor K beta and EBV or the proto-oncogene mutation which causes that, right? History, again, it's not in adults. You can use the term young adult, or because it happens in and around 30s, 20s in that area, or sometimes can have bimodal distribution, right? Children or an elderly. That's one classical finding. Second, you'll have generalized lymphadenopathy in few, localized lymphadenopathy in NLPHL. Very, very, very rarely involves Valdeus and extranodal. And one more classical symptom, the type of fever. Sure, Rishan. If they do, we'll do. I'll update you. Epstein fever. There's a very classical fever for Hodgkin's lymphoma. Look for this fever in the history and pain on alcohol ingestion. Not sure why yet, but pain on alcohol ingestion is something, again, very classical for Hodgkin's lymphoma, right? These two are very, very classical symptoms with respect to Hodgkin's lymphoma. Look for them in the scenario if they give, or if it's just a short note on Hodgkin's lymphoma, write them. These two are something which you'll expect for, right? Lymph node, what I'll have is, you'll have RS cells plus a varied amount of background inflammatory infiltrate. The background inflammation is very, very characteristic for me, more in equal quantities to the RSL. It's not just RSL. RSL plus background inflammatory infiltrate tells this is a Hodgkin's lymphoma, fine. Then divide them. I have classical, I have NLPHL, right? So a classical, there are 4 different types, and this is your last one, which is nodular lymphocyte predominant Hodgkin's lymphoma, right? So few words for everything here. Can anyone tell me which of these two are not EBV associated? Which of these are not associated with an EBV infection? The first and the last don't have involvement with Epstein-Barr virus. Rest 3 in the center are involved with Epstein-Barr virus, fine? So whenever Epstein-Barr virus is not involved, please remember they have a decent prognosis. Whenever Epstein-Barr virus is involved, prognosis kind of drops, fine? The first also does not have Epstein-Barr. NLPHL also does not have Epstein-Barr, fine? Right? So here, there is no EBV association. Here also, there is no EBV association. Okay. Mostly, this is the most common subtype seen in developed nations. And the type of RSL is, along with the classical RSL, I'll have lacunar variant of RSL. Okay, same. Empty space, that's all. That's a lacunae. Here, this is associated with an EBV. This has classical bimodal distribution seen in developing nations. What is more characteristic form here is, along with the classical RS cell, we have Hodgkin cell or a mononuclear RS cell. Hodgkin cell is a mononuclear RS cell, single nuclei, no binuclear thing, and also varied inflammatory cells. That's why mixed cellularity, right? Plus very, very, very varied inflammation background. Okay. Lymphocyte rich. Lymphocyte rich, again, these are also EBV positive. You'll have the classical RS cell, can also have mononuclear cell, that's your Hodgkin cell, plus background is purely lymphocytes, purely T lymphocytes, like a granuloma, right? Purely T lymphocytes. Lymphocyte depleted. The rarest form, HIV positive, EBV positive, worst prognosis. Why there is lymphocyte depletion? Because HIV can kill it. The same way HIV can also kill the RS cell. It's also lymphoid cell, right? So I can have mummified variant of RS cell, or the reticular variant, or a very, very pleomorphic RS cell. Pleomorphic, bad prognosis. You can easily link it. NLPHL, no EBV, seen in young adults, generally involves a single lymph node involvement, not generalized lymphadenopathy. Okay. And the RS cell here is the LNH cell, or our famous popcorn shape. Okay. That's how it is. Fine. So few important information. See, I am writing it clustered. But if you write one by one point, each of them will have easy 3 to 4 points to write. If it's a long answer, below everything put a cell, that's all. First, explain a classical RS cell, right? It's a binucleated outside nuclei plus eosinophilic nucleoli. This is very important. It should be an eosinophilic, very prominent nucleoli. It's a long answer. Draw this. Okay, I have something completely blue in color here. And in the center, I might have a pink nucleoli. Lacunar variant, draw it, same with the lacunae. Mononuclear, draw it, same, single nuclei. Popcorn cell, draw it. It's very simple to draw cell, popcorn cell. Okay, I have a nucleoli, popcorn cell, right? It's a long answer, elaborated. Short answer, write it small, right? Markers is the way I go and diagnose it, fine? If they ask RSL in 2 marks, you know what to write. Write about the classical RSL, explain its Reed-Sternberg cell, classical appearance, draw a diagram, draw the classical markers. That's enough, fine? Srimati, 1920 BCL6 is fine, but only for NLPHL. Because classical RSL is a crippled B cell, right? So here it is, CD15, CD30, and PAX5 being weak. It should be weak. Though it's a B cell lymphoma, it's a crippled B cell, does not have the classical markers of B cell. Only NLPHL has the classical markers of B cell. Though it is not required for you, but write this. 20, CD45. You are absolutely right. 10 will be positive, BCS6 will be positive in NLPHL, not another thing, right? And PAX5 will be strong. This is very, very important. PAX5 is a B cell marker. We read in BALL, right? PAX5. So here PAX5 is weak. So it's a B cell, dying B cell. PAX5 is very strong. So it's a classical B cell lymphoma, right? This will be positive for your 10 and 6 also. I'm not mentioning it, but these are something basic to remember, right? Treatment, you know your chemotherapy, right? Flex your pharmacology here, right? ABVD. That's your ABVD regimen. Long answer, explain what is A, B, and B and D means. Pathologists might not remember what is A, B, and D means, but they'll remember what is ABVD at least, right? And prognosis. The best is NLPHL. If you want to write in the order, then I have nodular sclerosis, then I have your lymphocyte rich, mixed cellularity, lymphocyte rich, and then lymphocyte depleted, fine? In the order of reducing becoming good to us, fine. That's about your Hodgkin's lymphoma, right? The last guy, you already tell about it. Tell whatever you know regarding CML. Random thing, Rishank. Same radiation, same. See, in lymphoma, the one problem is like I'm taking a risk by stopping TP53 whenever there's an processing, right? So, lucky we are not having the problem. That's all. Origin, myeloid stem cell. It's a chronic myeloproliferative disorder, right? Translocation 922 Philadelphia chromosome. Because of that, there's a translocation between BCR and ABL. In this, ABL is a proton cogene, so there's an increase in the ABL, which increases your tyrosine kinase. So once it increases your tyrosine kinase, which results in increased cell division because that's a transcription factor. That's it. It's a very simple thing. Pseudococcus will come in bone marrow, right? But we don't do bone marrow for CML, right? Yes. CML is a very simple diagnosis based on your microscopy, right? History, you know, no generalized lymphadenopathy here, right? Adult, massively enlarged spleen. Because of that, you can have a vague left hypochondrial pain. Okay. See, I always think about this. Whenever you are in a Viva, right? Suddenly there'll be a confusion whether spleen is in the left or right. I always use touch here. Okay, left hand side. Okay, it's the spleen. It's fine to take time in a Viva. Don't make blunder just because you want to be first. It's okay. Take your time. Vague left hypochondrial pain for CML, classical diagnostic morning, right? Peripheral smear. CBC obviously will have leukocytosis with classical shift to left. So what do I mean by that is, we'll come to origin. Just give me a second. Shift to left means you have all the maturing myeloid cells. Okay. You can write from blast, myelocyte, metamyelocyte, stab forms, neutrophils. Everything will be there in your microscopy. If you want, use the cheesy words of college girl appearance, garden party appearance. If not, ignore it. Left to shift, I wanted then the exam paper. And never forget this. Basophilia. These are only two things which I'm going to look in the exam paper. One of the close differential diagnosis right here itself is sepsis. Because sepsis also will have left shift, right? How do I differentiate? Where you use the term lab score. Lab score is almost negative or low or zero in CML, and it is increased in case of sepsis. Though it's not required, but if you want, write it. On a Viva, if they ask, tell, because no one uses lab score, right? So now I know it is CML. If I know CML, the next job for me is to phase it, whether it's in a chronic phase, accelerated phase, or blast crisis. As on date, these two are, as per the new WHO, these two are merged. Okay, now I have only chronic phase and then blast crisis. Only two things. I'm moving from 3-tier classification to 2-tier classification throughout the entire pathology. Easy to manage, that's all, right? Blast, basophils less than or equal to 20. So, okay, less than 20 should be there. And blast, what's the percentage? Should be less than, you guys tell me. Basophils more than or equal to 20 here. Leukocytosis, thrombocytopenia, cytosis, and also spleen, same or increasing in size. All these three are in spite of treatment. Okay. In spite of treatment, I'm having an increased spleen, very low platelets or very high platelets, and more WBC, which means treatment is not working, right? Okay. Here blast is from 10 to 19%. Here it should be less than 10%, right? Okay. So 10 to 19 is for me your accelerated phase, less than 10 is for your chronic phase, fine? Okay. Blast more than or equal to 20, in peripheral smear of bone marrow makes it an acute myeloid leukemia. Rishank, why AML is having a worse prognosis secondary to CML is CML is already a tumor. I'm having a normal tumor. On top of that, I'm having more and more and more new mutation, which is making the CML AML. So obviously it will have worse prognosis, right? Or I have extramedullary blast. This obviously will have the worse prognosis out of CML. The lifespan is very less when a CML becomes an AML. That's a blast crisis. Fine. Okay. So this is how we categorize. Then comes my investigation of choice. Investigation of choice simple. It's genetics. It's not bone marrow examination, but like TS said, there's a finding called as pseudo-Gaucher cells, which will be seen in case of CML. In bone marrow, has a cell called a pseudo-Gaucher cell, which looks like a Gaucher cell, blue color cytoplasm. These are actually macrophages. Macrophages having all the uh, ceramides due to self division. That's why it has pseudo-Gaucher cells. Pseudo-Gaucher cell, just since he took, I'm just adding it here, is a evidence of cell division. That's all. Whenever there is more cell division in bone marrow, you will have pseudo-Gaucher cell. So can I say in case of thalassemia, there'll be more cell division, hemolytic anemia? You will. So even in thalassemia major, I'll have pseudo-Gaucher cell. So it's not specific for CML. Fine. Blast is less. That's why we call it chronic, right? So if it's more, I call it acute. Fine. So it's not a finding for CML. I can see them in any increased cell division, pseudo-Gaucher cell, right? So diagnosis by genetics, I go for an real-time PCR or fish. This is preferred than a cytogenetics, right? Treatment, you guys know, you're going to give imatinib. If you know SOCAL index, I'm very, very happy. You can write the SOCAL index. SOCAL index tells me the prognostication. Imatinib, dasatinib, ponatinib, whatever drug you know about the tyrosine kinase inhibitor, you can put in forward that. Fine. Okay. That's with respect to your chronic myeloid leukemias. Fine. Try to draw the diagram. 1122 cell for everything. Blast, myelocyte, metamyelocyte, stab form, and neutrophils. Fine. Okay. I'm not one homework for you. I want you guys to go and read myeloma. Myeloma, only one table is required for me. Smoldering, sorry, MGUS, smoldering, myeloma, and then few findings in the bone marrow. Lots of varied amount of plasma cells. SLAB and slim and crab criterias. Last but not least, serum electrophoresis. Fine. More mutation, Rishank. So we'll have double Philadelphia chromosome, we have TP53 mutation. It becomes aggressive, that's all. When CLL can become DLBCL, when a squamous cell carcinoma can become a high-grade squamous cell carcinoma, when a carcinoid can become a small cell carcinoma, CML becomes an AML, same way. Fine. Okay. Thank you for your time. Any doubts, do let me know. If not, tomorrow I'll be talking about neoplasia. Neoplasia is very big. Let's see how we can focus few important points and recollect things. Right? Any doubts? If not, let's call it a day. Not more mutation, severe mutation. More is not always a number. CML becoming AML, I'll have more severe mutation, which makes that. De novo AML has a different pathogenesis, right? Both are different. Don't confuse it. Like I said, when you see you accepted that myelodysplastic syndrome, more mutation becomes AML, right? Same way CML, more severe mutation becomes AML. That's all. Sure, I'll do it. Okay. Thank you guys. See you soon. Bye bye.